Good afternoon, everyone. This is Jason Jones with the Community Technical Assistance Center, and I would like to welcome you to today's webinar, Love, Loss, and Grief. Today's webinar is the first of a three-part series entitled Working with Grief and Loss. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noises that may distract others from listening to the presentation today. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it is not visible, click the dialog bubble on the top right toolbar and it should appear. In order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we will address them during the Q&A portion of today's presentation. We are very excited to be joined by Nancy Tourette, a licensed clinical social worker and complicated grief treatment instructor at the Center for Complicated Grief at Columbia University. Once again, thank you for joining us. I will now pass it along to Nancy to get us started. Nancy?
Okay. So I'm going to be talking to everybody about love, loss, and grief. And I wanted to start off by telling you a little bit of who we are at the Center for Complicated Grief. So what had happened in like the 1990s, Dr. Catherine Shear began some pioneering work in complicated grief. She was in Pittsburgh at that time, and there was a subgroup of people who were depressed who weren't getting better. They weren't responding to the standard medication for depression. And she began working with these people and realized that these people have had a loss and were not responding to an antidepressant trial. So she got an NIMH grant and came to New York State Psychiatric Institute, where she had created this complicated grief treatment, and she was beginning a trial comparing 200 participants from her treatment to interpersonal psychotherapy, which is a very effective treatment for depression. And we did this in 2007. I was one of the main therapists who treated everybody in the complicated grief treatment, and we had a 70% success rate. And since then, Dr. Shear has published articles in JAMA and the New England Journal of Medicine, and the whole topic, the whole diagnosis of complicated grief has really taken off. So after the protocol was done, she went over to the Center for Complicated Grief, with her goal being to get the treatment out there to as many people as she can. She's taken this treatment worldwide. She's trained people in Hong Kong, in Italy, in Ireland. In 2012, she and I went over to Japan to train the mental health professionals to help the victims of the earthquake and the tsunami. So the goal of the Center for Complicated Grief at Columbia University now is to train as many people as we can in this very effective treatment. Okay, what I hope to explain today is to give people an understanding about complicated grief, to talk about the diagnosis of complicated grief, and to speak a little bit about how complicated grief differs from major depression and PTSD. Okay, so I guess you guys fill out this poll question, and I just keep going. Okay. Okay.
Oh, if you go back to the poll question, actually.
Okay.
So we're just going to give everyone a minute to answer the question, have you ever heard of the term complicated grief prior to this webinar? And on the right-hand of your screen, you should say yes, no, or unsure. We're just going to give everyone a few more seconds for that. All right, so it looks like we're pretty split, with 51 of you saying that you have heard of complicated grief, 53 saying that you haven't, and a few that are unsure and that didn't answer. So thank you all for participating, and that information is really helpful moving forward with the presentation.
Okay, so I should go ahead?
Yes.
Okay, all right. So the way we look at grief and loss is that when we lose an attachment figure, somebody we're very, very close to, we go into a state of bereavement. And grief is the response to the loss. It's permanent when someone dies, and it's very disruptive because we're not used to going into this state of feeling. Okay. We believe that grief is not one thing. It can be very different for different people. It can be a range of emotions, thoughts, behaviors. People can have physical changes when they're experiencing grief. And there are spiritual and social aspects that affect our grief reactions. Everybody grieves in their own way, and grief is different for different losses. Grief changes over time, and people grieve differently. Still, there are important commonalities. Okay, so what happens when we lose somebody we love? We go into a state of acute grief, which is the initial response to the loss. In acute grief, there are strong emotions. There is yearning, longing, sorrow, anxiety, guilt, anger, shame, interspersed with positive emotions. There are thoughts about the deceased, there's a sense of disbelief, and there are frequent, insistent thoughts and memories of the person who died. The thoughts about the deceased can be very, very prevalent, and it may be difficult to concentrate on other things. Now, there are different styles of grieving. People have very different styles. One style is proximity seeking, and what that means is people may want to spend the whole day doing photo albums, looking at photo albums, or people may be very avoidant of the reminders of the loss. I was working with a family once where the husband and the wife lost a 22-year-old child, and the husband's style of grieving was to put the child's pictures all over the house, and the mother's style of grieving was to avoid everything. So she would just like walk down the stairs and not look up because she couldn't see it. That can be very hard when people's styles are drastically that different. Grief changes over time. The thoughts and memories become less frequent and insistent. The sense of disbelief lessens. The intense emotionality subsides, and feelings of well-being are restored. Okay? Okay. And then the acute grief flows into a state of integrated grief where the thoughts and feelings are less intense. People have accepted the finality of the loss. There is a lot less disbelief. Grief finds a place in our hearts, and people make peace with the loss. The grief becomes less prominent and is just able to be in our hearts in a comforting, loving, yet sad way, a bittersweet way. In complicated grief treatment, we deal with the loss and the reconstruction of the self, that we stress and do work with a renewed sense of purpose and meaning and renewed connections to other, that we deal with the loss and rebuilding connections that have been affected by the loss. Grief becomes integrated as we adapt to the loss. Okay, so the three core processes that help our grief move forward are, number one, accepting the reality of the death. That can be a very hard thing to do, because for some people, this person is alive, and then all of a sudden they're dead. And it's a very, very bizarre concept. And that can happen even when people have been sick for a while. The job is to accept the reality of the death. Okay, the second job is to think about a future with possibilities for happiness. When you lose an attachment figure that is a very, very deep loss, you believe you'll never be happy again. You cannot envision a future with possibilities for happiness. So Dr. Scheer created this treatment in a way that very, very early on in this treatment, we talk about goals and aspirations. We ask the patient if they ever had a dream, something they wanted to do with their lives. It may not be realistic, but it's something. And what we're doing is we're pulling for positive emotions. So very early on, we try to regulate the emotion by reaching for positive emotions. The other concept here is changing our relationship to the person who died. That this person was an alive person, and now the person is a dead person. And people do it in all different ways. For example, if a mother has a child who died, she's got to think about, when people ask her, how many children do you have? Are you going to say one child or two child, or I had a child that died? It becomes something you think about, and you make a choice depending on your level of comfort. Okay, so really to summarize what I've explained previously is that we have a handful of very close attachment figures in our lives. These attachment figures are our cheerleaders, our supporters, people we want to be with, people we count on. And when we lose an attachment figure, we go into a state of havoc. Anytime there's a change in the attachment system, we get very, very shaky. For example, when adolescents switch from their connection with their parents to their peers, it's almost a crisis. So when you lose an attachment figure, you go into a state of bereavement whereby grief is the response. And again, the initial response is acute grief, which is intense emotions, disbelief, and the job then becomes to adapt to the loss. Most people adapt to the loss, and the acute grief turns into integrated grief, where the loss is accepted and the consequences of the loss are factored in to going forward. We think of this as a river that flows, that the river is flowing and goes forward. When we adapt to integrated grief, we accept the reality, we accept change relationships, and we envision a positive future. Okay, so a simple way to understand complicated grief is that complications come up that get in the way to the natural adaptation to a loss. We think of it as a wound complication, that if you have a wound and it's dirty and infected, it may not heal. So we go in this treatment and understand the complications and clean out the wound so that it can heal and the natural process of grief flows forward. Okay, so what are complications that get people stuck in grief? Okay, people can get stuck for different kinds of complications. One part is maladaptive thoughts, second guessing, grief judging, catastrophizing the future. I worked with a mother whose daughter went out during the storm Sandy. The daughter went out to walk the dog, and a tree fell on her and she died. So she became very, very involved in second guessing. I shouldn't have let her go. I should have thought about it with her. Why did she have to go walk the dog? The world is very dangerous. That's an example of the maladaptive thought. And what happens is people in that scenario spend a lot of time involved in, she shouldn't have done this, she shouldn't have done this. And what that does is creates a cycle of second guessing. So rather than accept the loss, they're stuck in this trajectory of it could have, it would have, it should have. That is a way of not dealing with the loss, okay? Another type of behavior is dysfunctional behaviors. So I worked with a woman who lived in Westchester, and her 30-year-old son lived in Pennsylvania with his wife and his infant baby. And this woman was a nurse, and her son would always call her and say, I don't feel well, this and that. And the mother would say, go to the hospital, go to the hospital. And the son called at one point and said, I don't feel well. And for some reason, she did not say, go to the hospital. And he ended up having a pulmonary embolism and died. And this woman stopped going to work. She literally sat in her house. She wouldn't leave the house to go to a restaurant. She wouldn't go to a shopping mall. She was scared she would find people who would say, oh, I'm so sorry. So she just sort of did what she did, run in and run out. And she came to our treatment protocol, and she drove down, had big dark glasses, ran into the clinic, and then ran out. People can really avoid things. I worked with another woman whose son jumped in front of a train in a small town in Westchester, and the train station was sort of in the middle of town, and she kept avoiding the train station, which meant she had to drive all kinds of circles around to get where she wanted. Sometimes people use substances to sort of numb them. Other times people have negative health behaviors. People can very much not want to go back to a hospital or doctor visits, and they just let things go, like they don't have mammographies, and they just neglect their health. Okay, another problem comes up, regulating feelings, that people are very, very, very flooded with negative emotions. The negative emotions are extremely intense. And one thing, as I said, we do early on in the treatment is encourage people to think about goals and aspirations. we encourage people to set the loss aside and bring in positive emotions. What happens when they are successful in doing that is they can tolerate the grief better because it's not as intense and it's a little bit more balanced. The people who have very intense negative emotions end up exhausted. They just can't go on. It is extremely draining. Another piece that can get somebody stuck in complicated grief is a severe social environmental problem, lack of any supportive companion blamed by others, homelessness in poverty, or loss of employment. So I had a patient that I worked with. She was around 60 years old, and she had gone to a casino in Atlantic City, and with her partner, her fiancé, and he had an aneurysm. And they lived in a house in Virginia, and he died, but they weren't married. So what the family immediately did was block her from taking her stuff out of the house and did not help her come to the funeral, get to the funeral, say goodbye. And we look at that as sort of a toxic social environment that can also contribute to being stuck in complicated grief. Okay, so what happens when these complications occur is the acute grief does not flow into the integrated grief. The process of adaptation cannot move forward. So the complications wipe out the ability to adapt and to reach the state of integrated grief. And in the treatment, we work with complications. The estimated population of bereaved people is 15%, and the rate is much higher, about 14% of those bereaved by a violent death. Okay, so there is criteria in the DSM-5. What has happened is the Center for Complicated Grief has really adapted the ICD criteria, ICD-11, but I'm just going to go over the criteria in the DSM because it's interesting to see how they do it. That it's at least 6 months when the individual experienced the loss of someone. We use the 6-month criteria in our protocol. It's a little bit arbitrary. Some people can see it as a year. And the individual has experienced at least one of the following symptoms to a clinically significant degree, which means persistent, intense longing and yearning for the deceased, persistent preoccupation with thoughts and or memories of the deceased, and one of the following in section C, which is sadness, anxiety, disbelief, feeling like a part of oneself had died. I worked with a woman whose husband died in 9/11, and she really would talk about how she felt her body was cut in half, that she lost her arm. People can feel that way. People are shocked, stunned, numb, troubling thoughts about the death, loneliness, strong emotional or physical response to reminders. Impairing grief has persisted for a period of time that clearly exceeds expected social, cultural, or religious norms for the individual's culture and context, and for at least 6 months since the death. The disturbance causes clinically significant distress or impairment in social, occupational, or other important areas. Okay, so a simple way to recognize complicated grief is to be very aware that there is intense feeling or longing or preoccupying thoughts and memories that interfere with functioning. So the ICD-11 proposal, which is what we advocate, is persistent, pervasive longing or preoccupation with the deceased, causing significant impairment in important areas of functioning. At least one additional indicator of intense emotional pain, such as sadness, guilt, anger, denial, blame, difficulty accepting the death, feeling one has lost a part of oneself, emotional numbness, persists at least 6 months and clearly exceeds expected social, cultural, or religious norms. It can be sort of amazing that people can go through death, a funeral, and just stay very numb and really not process the death, which is, it's surprising, but many people just don't process the death. Okay, so I'm going to talk a little bit about the difference between complicated grief and depression, and then I'm going to talk a little bit about complicated grief and PTSD, and a little bit about the treatment, and then we can have some questions. So our depression guy feels he's a failure. No wonder, he has no friends, he's not motivated to do anything and feels down. Okay, grief and depression are not the same thing. In major depression, there's a pervasive loss of interest or pleasure, whereas in complicated grief, there's a loss of interest or pleasure related to missing the loved one. In MDD, there's pervasive dysphoric mood across situations. In complicated grief, there are pangs of emotion triggered by reminders of the loss. In major depression, there's preoccupation with low self-esteem and a general sense of guilt or shame. In complicated grief, there's preoccupation with the deceased, guilt or self-blame focused on the death. We see a lot of self-blame. People who were caregivers. I was working with this one man whose wife died of pancreatic cancer, and they actually had a very nice death scene where the wife was at home and the kids were there and they all got into bed and said goodbye. And the husband's feeling was this was awful. He couldn't fix it. He fixed everything. He couldn't fix it. And really, when we talked about it, he was really able to see that this was a very, very beautiful death scene. And that really helped him a lot. Okay, so MDD has general withdrawal from activities and people. Intrusive images are not prominent. Yearning and longing are not usually seen. In complicated grief, there is avoidance of activities, situation, and people because of the death. There are intrusive images of the deceased. People get recurring intrusive images, and there's yearning and longing. Okay, this is our PTSD guide. Okay, and the difference between PTSD and complicated grief is that PTSD has a triggering event, which is a threat. complicated grief has a triggering event, which is a loss. The primary emotion with PTSD is fear. The primary emotion with complicated grief is sadness. There are intrusive thoughts of the event in PTSD, and in complicated grief, there are intrusive thoughts of the person. PTSD is fear-based, and complicated grief is loss-based. Okay, so I don't know if we want to do questions or if you want me to talk a little bit about the complicated grief treatment.
I think it would be great if you talked a little bit about the treatment, and then we could go into questions thereafter.
Okay. Okay. So this treatment is a 16 to 20 week treatment, and it's a very structured treatment. And I think of the treatment in thirds. In the first third, we spend the first session really talking about attachment figures. Who are the person's attachment figures? Who has been important to them in their life? And what are these styles of attachment? In the second session, we do some psychoeducation about complicated grief. So we show our charts and explain how grief flows like a river from acute grief to integrated grief, and there are reasons why people get stuck. And we focus on what the patient feels has got them stuck. In the third session, we give the patient an opportunity to bring a family member in so that we can provide some psychoeducation for the family and also explain to them how one of the strategies we're going to be using in this treatment is a prolonged exposure intervention, whereby we're going to ask the person to close their eyes and go back to the moment that the person realized the person had died and tell us in the present tense where they are and what they see. So, for example, it could be I'm standing in the hospital room, all of a sudden my mom gags, and they can go on in that. We make a recording of that, and we have the patient take it home and listen to it once a day to bring down the level of emotion. And what happens when the level of emotion comes down is thoughts change, and then that gives us things to work with. So we like to explain that to the patient, and we do this revisiting exercise in the middle of the treatment. We may do it 4 times, and we work with it in that way, and that's a very, very integral part of the treatment. In the last part of the session, the last third, we ask the patient what's left, and we focus on what's left. There may be a lot of ambivalence about giving up the grief. Some people can think it's a betrayal. So we sort of, in the last third of the treatment, attend to issues that are still there. Throughout the treatment, we're using a whole bunch of different techniques. We have people filling out a grief monitoring diary where they can record if they've been triggered and to what level. We like them to know how, what triggers them. We also work with difficult times, holidays, managing difficult times, and a whole slew of issues. It can be very different for some than the other. So do we want to open it up for questions, or?
Yes, thank you so much, Nancy. So as a reminder, please continue to submit questions to the chat box, and I will take everyone through the questions that we have so far. So the first question that we have is, how long does acute grief last? And can a person have acute grief for more than 5 years? And if so, when does it become a depression?
Okay. Acute grief usually lasts about 6 months to a year. The hope is that acute grief flows into integrated grief. If acute grief does not flow into integrated grief, there are probably complications that block the adaptation to the loss, and that becomes a situation where you're stuck in complicated grief as opposed to depression. It's not depression, although depression may be comorbid.
Great, thank you. The next question we have is, can the circumstances of the death alone be complications, such as a death by homicide?
Sure. Yes. The circumstances, there can be car accidents, there can be homicide, there can be suicide. Yes, the death in of itself can be a complicating factor.
Great. Another question that came in was, can complicated grief include loss of a relationship or loss of some other sort that's not necessarily a death?
Okay, well, for the purpose of complicated grief treatment, we believe there has to be a body, and we do a lot of work with the body. If you're looking at the loss of a relationship, or a person may be developing Alzheimer's or a stroke, that is more of an ambiguous loss, whereby the physical presence of the person is there, but they've lost their functioning. So it is a much different loss.
Great. The next question is it normal to feel a sense of sadness every year on or after the anniversary of the person's passing? And how would you consider coping through that?
Okay, yes, it is very normal to feel sadness on anniversary dates or special memories. We suggest that people cope with that by honoring the person who died and doing something that is soothing and giving to themselves. So you go to the loss and honor the person, and then you do something restorative to yourself.
Great. Thank you. The next question is, if someone already has major depressive disorder, are they more predisposed to complicated grief? And therefore, is it harder to treat?
I don't think it's harder to treat. I don't know what the data results are on the first part of that question. So we might need to get that answer from somebody who works with the statistics. I don't know the answer to that.
Okay, that's perfectly fine. The next question is, do you incorporate Kubler-Ross's stage of grief at all in your psychoed component of the treatment?
No.
Okay, and is there a specific reason for why that's not included?
Well, we look at grief very differently. We don't look at grief as going through stages. We look at grief as going into acute grief that in time adapts to integrated grief. If it doesn't adapt to the integrated grief, complications come up and prevent that.
Great, thank you. Okay, for a child who has experienced a lot of developmental trauma, disrupted attachments, disengaged parenting, multiple losses, how would this connect in with the concept of complicated grief?
Okay, well, I think what you'd have to do is do a very in-depth assessment. I had somebody come to me who lost her mother. She was in a very abusive relationship with a man, and she was depressed. And what you do in that situation is you really do a very thorough assessment and make a decision with the patient about what the primary problem is, and then deal with that. There can be a lot going on, and it can be very important to be clear on, you know, what to approach at what point.
Okay, fair enough. Another question is, can this diagnostic criteria extend past a human being, specifically the loss of a pet?
Yes, it can, and I once treated a woman who had lost a pet, and you just sort of adapted the treatment for her, and she did very well. So it can be for a pet loss, too. I've also treated somebody whose kids were kidnapped, and that's a little bit different, too. So you can, if you really know the treatment well, you can adapt it in that way.
Great. Another question, well, a few of the questions that we've received pertain to the diagnosis of both complicated grief and PTSD. The first being, is it possible to be diagnosed with both? And how do you go about treatment if that is the case?
Yes, it is possible to be diagnosed with both. The revisiting exercises that we do in this treatment are very similar to the prolonged exposure exercises that one does in the treatment of PTSD. So we have found that when we have our patients revisiting the loss in this way, it can be a treatment for that. A lot of times, intrusive images disappear, and that's very, very effective. I have a patient I worked with, she was like a 20-year-old. Her mother went upstairs and put a bag over her head, and it was a suicide. And as we made more sense of the timeline and the experience, the intrusive images changed. So that can be helped in that way.
Thank you. One of the things that you noted was that a traumatic loss can lead to complicated grief. Something that many of our participants are wondering is, are there early intervention strategies to minimize the onset of complicated grief?
I think we're reluctant to move in before 6 months, that there needs to be a chance for the natural adaptation. If after 6 months people are struggling very badly, you could start offering complicated grief treatment then. But I would really give it 6 months. I have worked with a couple of people whose husbands died in suicide, and we've spent a lot of time talking about that, because the issue there is they just don't understand how this could all happen. So what I've done there is sort of explore that and keep my eye on it and see where we go.
Understandable. We've received a lot of questions with regards to the diagnostic criteria of 6 months. The first question being, why is complicated grief considered after 6 months while the norm of grieving within Western cultures is about a year?
Well, the 6 months was arbitrary, and people, you know, could also give it a year. I mean, it's arbitrary.
Okay, thank you. one of our participants said, as a practitioner, are there any tips that you can provide that can help when facing counter-transferential issues? For instance, working with a patient that reminds you of a lost parental figure.
Well, you know, you have to be very clear with yourself that there may be similarities, but this is not your loss, and sort of use the rational thoughts to keep reminding yourself of that.
Great, thank you. Another question pertains to long-term deterioration through dementia or chronic illness. How does that play into the concept of complicated grief?
Okay, well, again, you know, we're talking about an ambiguous loss, and what happens when a person with Alzheimer's dies, in time you sort of forget the sickness of the Alzheimer, and it's easier to remember them as they were. You know, you can look at somebody like pre-Alzheimer's and post-Alzheimer's, but again, you're in the area of ambiguous loss.
Thank you. Another question is, can you give us a summary of what the grief monitoring logs look like, or provide an example?
Okay, so we ask everybody at the end of the day to rate on a scale of 0 to 10 some situation that triggered their grief up. For example, let's say a mother lost a child, and every time she would go to the baseball diamond, her grief would get bumped up to like a 10. So she would write that on the grief monitoring diary, that's a bump up to a 10. Something that lowered her grief might be cooking, because she has to sort of focus and concentrate on it. And then in grief, we also ask how much of the day was spent in complicated grief. So that's what the grief monitoring diary looks like.
Perfect, thank you. The latest question that came in, is it recommended for someone whom is caring for a family member or friend with a terminal illness to start seeking treatment before the person passes away?
You know, that depends on the situation. It may not, because it's a much different picture when the person dies. The issues are much, much different. So, you know, I think that's a complicated question where that's too specific to the situation to sort of create an across-the-board policy.
Great. Another question that came in really pertains to resources that you have related to complicated grief. Folks are wondering, where can they find more resources, and is this a manualized treatment that's available?
Yes, it's a manualized treatment, and the best thing to do is to attend a workshop through the Center of Complicated Grief. These slides went up. The Center for Complicated Grief offers treatment manuals, assessment tools, and the workshops are really, really helpful in terms of helping people get started with the treatment for complicated grief.
Perfect. Thank you so much. And with that, I would like to thank you again, Nancy, for answering all of our questions and providing such a great presentation. Really a beginning for folks that are interested in learning more about complicated grief.
Right. Absolutely. My pleasure.
And I'd also like to thank everyone else for joining our presentation today. We want you to please check out parts 2 and 3 of this series. Part 2, Saying Goodbye, Families Coping with a Loved One's Terminal Illness, on December 6th. And Part 3, Beyond Kubler-Ross, New Perspectives in Death, Dying, and Grief, on December 14th. If you have any other questions, please contact us at ctac.info@nyu.edu. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. On behalf of CTAC and our presenters, thank you for joining us and enjoy the rest of your day. Thanks, everyone.